Ara poso, jo què sé,
Recording in progress.
poso un keynote, ara si s'obre i obro qualsevol presentació que trobi. S'obre?
I sobretot fluid, perfecte.
Vale, doncs surto. Deixo de compartir pantalla, vale? Prova tu, Francesc.
Vaig.
Bueno, o que me muteen aquí, porque si no, si hacemos ruido aquí se va.
Uterine artery, es veu molt bé, Francesc.
Sí.
Vale, doncs a veure, els que tenim solucionat, comencem la sessió i després, mentre, amb calma, que vagin provant lo del cable de l'Eva.
Sí.
Vale?
Pot ser que hagin donat accés als alumnes ja sense avisar-nos?
De moment...
Sí, veig 236.
236, vale. Vale.
Okay, then we can go ahead, Letty.
Okay. Good morning or good afternoon. We are here in the first session of this advanced course in maternal fetal medicine. We are very sorry to say that we had some connection problems, that we had to start a little bit late, and we apologize for that. And we will start right ahead with the session. We have Dr. Frances Figueras and Eduard Gratacos for the discussion, and also we have Eva Meller for a real-time practical aspects of Doppler exploration, but we are trying to figure out that. So we'll start with the directors of the course, with Dr. Frances Figueras.
Okay, be very welcome to this session, but above all, be very welcome to this international edition of the course on Advanced University Certificate in Maternal Fetal Medicine that will unfold during these next 5 weeks, and that will include 10 modules. What it makes it unique, it's hybrid program, where each module will has 2 components. First, online classes that are given by internationally renowned experts in each field that will provide, schematic updates on correct knowledge and will offer clear diagnostic and algorithms based on the best available evidence. These classes, that are available 15 days before the session, the streaming session, and will be left open during 1 year for consultation. And the second component of each module, like today, it's a 3 hours streaming session with a real tasking demonstration that we will try to demonstrate a Doppler evaluation today, but mostly it will be followed by ample time for discussion, and during which your interaction it's essential, and that interaction will significantly contribute to the success of the whole session. So I hand it over to Eduard Gratacos to welcome you, and then we can start today's session.
Hello, everybody. Thank you very much. We are very happy to have you here on this streaming session, the first one, as Francesc has said. We have more than 300 people, and it's raising the number. We have more than 400 people connected to this course, and so we hope that everything will go smoothly. We have not started smoothly because we have had a very serious technical problem just 10 minutes before starting the session, and that's the reason why everything has started later. And the plan was to start with a demo, ultrasound session and discussion, but because we want to be sure that the transmission is going to be perfect, we prefer to start with the questions. So we will start opening an open questions and answers session, have discussions on the different aspects that we discussed during our lectures about the identification of the small fetus, the distinction of low risk versus high risk, more for gestational age, and the classification of severity, and then the management. So I hope that you have sessions. We have Leticia Benitez coordinating, moderating the session with us. She will be receiving your questions and transmitting. And also, if someone is willing to ask the question directly, we can give you access. Hopefully, we will have the technical things solved to do that. Normally we do it and it works very well. And so whoever wants to make a question directly, and then please do so. And I don't know, Leticia, if we have something to start with, not to delay any further. If there is any question, any request.
Any question yet, but I asked you to use questions and answers in the chat, to use that for the questions. Well, we'll just receive one, actually. Yeah. They are asking, they are asking about the gestational age to request the biochemistry for placental growth factor. So it's not very clear, Luis, if you can clarify that.
The gestational age to request antigenic or antigenic factors or the ratio.
The-
But
case,
that probably belongs to the session on preeclampsia.
no, but because we talk about a little bit for the diagnostic criteria of fetal growth restriction. I would say that the role of androgenic factors in fetal growth restriction is quite limited. It's not like in preeclampsia that we will discuss much more in detail. As mentioned, we consider that they can be used as an additional criterion for the diagnosis of the high-risk small fetus. So when you want to classify small for gestational age versus fetal growth restriction, you then you can use I wouldn't say the traditional, they are not traditional, but they were, I mean, we put them together like 10, 15 years ago. So you put together a very small estimated fetal weight, less than 3, a very high uterine artery, more than 95 centile, and a low CPR, self-representative ratio, less than 5. If you had any of these 3, you could say, okay, this baby is fetal growth restriction. There is a good evidence that you could add a 4th criterion, which is the ratio of androgenic factors. You could use a placental growth factor, or you could use a ratio, the soluble fluid by placental growth factor. And if they are above the cutoff that we normally use for diagnosing preeclampsia, if they are above the cutoff, then you could say, okay, this baby's fetal growth restriction, even if the other criteria are okay. We have recently shown that they are independent predictors, and therefore you can use them. When would be the time to measure them? Because that was the actual question. When would be the time to measure them? And the time to measure them is at the time of diagnosis. So when you dissect the small fetus at the time that you are evaluating all the risk parameters, then if you have them, you could measure androgenic factors. If you don't measure them at the time of diagnosis, but you measure them later, that would be okay as well. If you have a small fetus that was detected by 33 weeks and you measure androgenic factors at 37 or 36, that's fine. I mean, if they come up abnormal, then you can say, yes, this is a fetal growth restriction. And I think, Frances, you wanted to show some data.
Yeah, something that illustrates well your point, that these first 2 columns are reflecting the detection rate for adverse outcome among late onset SGA babies. And you can see that the Doppler parameters could be replaced by the androgenic factors. But regarding the question whether they add together, the answer is not. As you can see here, when we combine all together, there is not a significant increase in the detection rate for adverse outcome. So I think that the bottom line of all together is that the androgenic factors could replace the Doppler evaluation in settings where that evaluation is not available, but they do not add together. Okay, is there more questions, Leticia?
Yeah. Maybe we can start with this one that will connect with the real-time task evaluation. They were asking how can we practically do the Doppler measurement of several parameters, umbilical artery, MCA. But I think we will do that later on. And also, what are the common errors that can be made and how can we avoid them?
Okay, that's an excellent introduction to the session. If you want, we can order the discussion going vessel by vessel, and if it's fine, we can start with the uterine artery Doppler. And let me share with you some slides that addresses the technical aspects of the uterine artery Doppler. Here it is. Can you see my screen that is shared?
Coming up,
Yep.
yeah.
Good, perfect then. Well, you know that the uterine artery Doppler can be evaluated both transvaginally and transabdominally. And you know that transvaginally it could be done throughout the pregnancy, and it's done starting with a sagittal plane. You know that during this examination, the vessel is located at the level of the internal os. Here are the main pitfalls that we can make, and how we should start our evaluation in a mid-sagittal plane, and then we move the probe laterally until we can see these images here that are the vessels. Then we apply the Doppler. We have to adjust the settings and perform a proper zoom, and then we have to insonate the vessel that corresponds with the uterine artery Doppler. And regarding the pitfalls that we have during this vaginal evaluation of the uterine artery Doppler, one mistake that we can make is that we can insonate a vessel other than the uterine artery Doppler. And this is detected first because of the anatomical location, because when it comes to the uterine artery Doppler, it should be located at the level of the internal os. And also a useful tip to identify this mistake is that the peak systolic velocities, they are lower than expected. As a rule of thumb, I would say that a peak systolic velocity below 60 should be suspected not to be corresponding to the uterine artery Doppler. That's a very common mistake. Transabdominally, we have the same problems, and we also have some common pitfalls. And the first one is the same than transvaginally, that is insonating a vessel that it's different from the uterine artery Doppler, and we avoid that by locating the vessel at its crossover with the pelvic vessels. We have to insonate the vessel next to the crossover, 2 centimeters below. And I said below because by insonating it below the crossover, we make sure that we are not insonating any branch of the uterine artery Doppler. Here is where it should be insonated, and here you can see some of the common mistakes that we perform. Well, that one is a quite obvious one, that not the pelvic vessel should be insonated, but the uterine artery Doppler. Here you can see both vessels here superimposed. And here you can see the branching that I said to you. If we locate the vessel above the crossover, we can make the mistake of insonating a branch of the uterine artery Doppler. Here is what is happening. You can see here that we are insonating an arcuate artery. And as I said, for the transvaginal approach, you can see here that a clue is that the peak systolic velocities are below those expected. Let's say 60 centimeters a second. And well, these are the quality criteria for insonating the uterine artery Doppler, both transvaginally and transabdominally. And now, Letty, it's time to make questions regarding the technical aspects of the uterine artery Doppler, if there is any.
Okay, they were asking what size of the Doppler gate you recommend to use. How many?
That's a very good point. As a rule of thumb, it has to be the same size than the vessel.
Okay, and the angle of insonation should be less than 30, or if it's not necessary in this vessel?
Less than 30, it's fine. Yeah, especially for the transvaginal approach, sometimes we don't have a perfect insonation angle of below 15. So I would say that less than 30, it's an acceptable criterion.
But you should aim at less than 30 in all vessels. The only
Well, yeah.
vessel where you have some permission to skip this rule is the ductus venosus, as we might discuss later. Okay, I think we could move forward to other questions that are not as much related with vessels, because if we have the occasion to do the demonstration, we can discuss that with real images.
Okay, so moving to detection, there is a very good question that we have received, that what happens, because we're proposing to perform the third trimester ultrasound between 35 to 37 weeks. So how can we reliably detect a iugr at earlier gestational ages? Like, what's our proposal?
Very good question, and I think sometimes we address that in our presentations. And this question has to do with this fact that you deal with a lot of small babies later in pregnancy, but certainly there is a big deal of cases where fetal growth restrictions happens earlier. And if you are doing your ultrasound at 36, 37 weeks, as we recommend, of course, how could you detect the very early cases? And the answer is that there is not an ideal moment for the detection of both. So the answer is that you detect late onset directly, and you detect early onset essentially by establishing a high risk and then doing more ultrasounds. So essentially, how can you do that? So we do that by several ways. The first one is you do screening for preeclampsia in the first trimester. These patients are at higher risk. If you are doing biometry at 20 weeks, ideally, if you can measure the biparietal diameter at 12 weeks, you can calculate the conditional growth of this biparietal diameter, and then you're going to have an identification of cases where this growth has not been optimal, and you can identify them as high risk, and you can then. I don't know whether you are seeing my questions and answers.
Yeah. Yes, we are.
Okay. I'm sorry. I am hiding everything. Okay, now the screen should be clear. Eh?
No, we're just seeing your screen, and we're.
The questions and answers, you were not seeing them. Okay. I was wondering because sometimes Zoom is showing you some things that I. And the third is the high risk. We use our own list, but we have adapted it from the Royal College high risk. So at the time of doing your second trimester ultrasound, you can check for a number of high risk situations. There was a previous preeclampsia, previous growth restriction, obesity, smoking. And then if there is a high risk, then this patient is classified as having high risk. And then if any of these three comes up as positive, then you do scans at 28, 32, and 37, and not only at 37. So that is the approach. And if we went to, that is the small fetus, and I'm going to skip that. But if we want to summarize, yes, I have a slide here which summarizes. So the summary is that you do your first screening, your first trimester screening for preeclampsia. You measure the BPD. That is the ideal patient. Okay, we know that in some countries it is difficult to have all your patients in the first trimester, and that, well, what can we do? Then you have to live with that. But if you can do the perfect and the optimal approach, that would be first trimester. Second trimester, you take into account whether there was high risk for screening in the first trimester. You measure the BPD and you measure the relative growth of the BPD, and then you check whether there are high risk factors according to any list of criteria. We recommend the Royal College one because it is very good. And then you're going to classify two populations. High-risk population, which could be between 5 and 10% of all your pregnant women, in which you are going to do more ultrasounds, and then you're going to detect the early small fetuses, and a low-risk population in which you're going to go directly to the 36, 37 scan and detect the late small fetus. Okay, so that could be the approach. And with that, you cover everything.
From a pragmatical point of view, Eduard, let me share with all the participants the checklist that we are using to identify at early in pregnancy those that should be performed serial scanning. Whenever one major criteria of these listed here is met, or three or more minor criteria, then a serial follow-up is recommended. And actually, there was not a good evidence regarding that approach, but we have quite a recent evidence showing that in those women meeting this criteria for high risk, so those women that should be offered a serial scanning, when we fail to perform that serial scanning here in this black column, you can see that the risk of a stillbirth increases by 3. So it's a kind of malpractice not to perform a serial scanning in those women at high risk early in pregnancy.
Okay, so moving on. We have 2 questions that are kind of related. That one of them is that if you diagnose a Doppler anomaly at a gestational age that you should deliver the baby, for example, they say that diastolic reverse flow at the umbilical artery at 34 weeks, for example, would you deliver the baby right away, or do you repeat the Doppler the following day to confirm the findings?
Well, that's a very good question. And I think that depends very much on the finding. But if it's a very alarming finding, then you could wait for a few hours. And if it's really, really alarming, you could then consider. Of course, you always have the consideration of whether you should give corticosteroids. So certainly when we are at 28, 29 weeks, 30 weeks, corticosteroids could really change the prognosis. If we are 34 and 5 days, maybe, and you are finding something really ominous. In general, our recommendation would be to check in a few hours, to combine with the CTG to see how things are really going. I would say that's quite uncommon to find something very unexpected, and I certainly look very much for an external reason. Look very much that the patient is not developing preeclampsia, because something that you will rarely see is that very abrupt changes in a fetal growth restriction, unless there is an external insult, and preeclampsia is a very common one, of course.
I agree that in general, it's not a good advice to rush to the surgical theater in cases of fetal growth restriction, because the natural history of placenta insufficiency is well known, and there is no need to rush. So in general, it's a good idea to confirm the Doppler findings in the following hours. Probably it's not needed to wait several days, but if you have the opportunity to repeat it in a few hours, it will give you an extra assurance that Doppler is reflecting a pathological condition. And probably that it's a good point also to address one common question that arises in these sessions, is that whether the 2 arteries, for instance, should be the 2 umbilical artery Doppler arteries should be affected in order to declare an abnormal pattern, or only one of them. And again, as a rule of thumb, the abnormalities should be present in both umbilical artery Dopplers. Because whenever there is only one abnormal umbilical artery Doppler and the other one is normal, that is reflecting a non-pathological condition. So it's a good idea also to take into consideration for clinical purposes the worst of the 2 arteries.
Yeah.
Okay, so related to that also, what happens if we have classified a fetal growth restriction baby and then we see a Doppler improvement, maybe related to corticosteroids or not? Should we reclassify it, or should we consider the highest stage, let's say?
Yeah, well, okay, these are I think two different questions. The first one is that if the stage can improve, and the answer is yes, because we are talking here of a hemodynamic condition that is influenced by many other factors, and so it could improve, and we have to update in each visit which is the stage. That's one question, and the other question is whether an improvement after the steroids has any clinical significance. And when it comes to that question, the answer is no, because it's a common finding to see an improvement, but it's not reflecting any cure of the placenta. It's reflecting the honeymoon effect of the steroids that can last up to 4 or 5 days. So we never have to change our clinical indication of a delivery because of an improvement after the steroids are given.
So the short answer is don't change your staging because there is an improvement. It's a false effect and maintain your initial decision.
Okay, Frances, you were saying that you will indicate corticosteroids, for example, in that clinical case, but are we indicating corticosteroids at any stage or only if we are planning to deliver?
That's also a very good and pertinent question because the steroids should be given whenever the indication for delivery has been made. It should not be given electively in case it worsens. So whenever we have the indication to deliver, it's when the steroids are given. There is an ongoing debate whether corticosteroids make an improvement in fetal growth restricted babies, because most of the evidence that we have on the benefits of corticosteroids, they excluded the fetal growth restricted babies. But do we have good observational evidence? And let me share here my screen. We have good evidence from observational studies in fetal growth restricted babies that actually the steroids benefit these fetal growth restricted babies to the same extent than the other non-fetal growth restricted premature babies. So the answer is yes, we should give steroid for lung maturation, but we have to avoid multiple doses. And let me share with you which are the effects of multiple doses. We know that mainly in those cases that are not going to deliver preterm, so those cases in which the steroids are given liberally and a selective measure, you can see that there is a detrimental effect on neurodevelopment. So multiple doses should be always avoided. Only single doses when the diagnosis of delivery has been made. And here you can see the general recommendation, always below 15 weeks and never above 37 weeks.
Okay, related to that, they are asking if we should recommend hospitalization in any case, or what's our opinion on that?
Well, normally that's an arbitrary decision. There is nothing very well demonstrated, but in general, if you think that there is no preeclampsia, of course, and you have a stage a fetus with reverse end-diastolic velocity, we normally would indicate hospitalization because this patient requires a very frequent follow-up, actually daily. This is what we would call a stage 3. And normally for just absent end-diastolic velocity, that could be that could depend. I don't think you can really make universal statement. That depends very much. You have a patient that lives at a reasonable distance from the hospital, that she understands well things, and you don't think she has a severe preeclampsia, of course, because that would be a big mistake. Then we would normally follow her in an ambulatory manner. So the cutoff would be from stage 2 to stage 3, but again, with a lot of caveats and considerations depending on the characteristics of the case and how do you think this patient is going to understand things, how is she going to comply with follow-up. So, and of course, they never look the same at different populations, and that's why I think these recommendations have to be qualified according to your setting.
So regarding medication as well, are we giving routinely magnesium sulfate for neuroprotection before 32 weeks, or what's our point?
Yes, the same applies for fetal growth restriction and magnesium sulfate that we discussed for steroids. There is no good evidence in fetal growth restricted babies that the magnesium sulfates makes any benefit, but because generally speaking, there is an improvement in perinatal outcomes in preterm babies, that it's indicated always below 32 weeks and in selected cases below 34 weeks. We are, for instance, indicating magnesium sulfate below 34 weeks. And that's a general rule that you can apply. Let me again share my screen with you on that. That's the general evidence that we have for the magnesium sulfate that applies to preterm babies. And in most of these studies, they do not stratify for fetal restriction or regarding the results. But we have a quite recent series that evaluated particularly in growth-restricted babies, showing that it seems that the effect of the magnesium sulfate always applies also to the fetal restricted babies. So we indicate them in the same way than we do in preterm babies.
Okay, so now regarding steroids, still that they are asking what's our planning to the new Doppler evaluation after the steroids, because if they will alter Doppler evaluation, should we wait for a few days to do a new one, or what's our?
No, you should keep the same follow-up.
For the same reason, you don't change the stage, you don't change the follow-up.
No, because it can progress to a higher stage. So it would make no clinical sense to not look at the Doppler, because it can progress, for instance, from a stage 2 to a stage 3 or 4. So the same follow-up.
And anyway, the intervals are quite short after stage 2. In stage 2, when you have absent and diastolic velocity, you should see this patient back in 48, 72 hours at the latest. So it makes no sense to delay this any further.
Okay. You were talking before about placental growth factors, and they are asking if we don't have them available in our setting, is the estimated fetal weight combined with Doppler have the same prediction value as the using the placental growth factor, or they have different?
Okay, as we said before, we've done some recent studies to understand what was the value that these factors add. We had published some data more than 12 years ago, but we have repeated another study, and I think here. Yes, okay, so I hope you can see my screen now.
Yep.
So we've done a study with these almost 500 cases of small fetuses, and we have seen, okay, what is the prediction? How do the markers work? Okay, and this is the classical way, I would say, that we repeat once and again: very low estimated fetal weight, uterine artery, CPR. How do they work? Well, they detect that there is going to be adverse pregnancy outcomes in 88% of cases, and actually they detect very much and very well that there are going to be complications like preeclampsia. Doesn't mean that they are going to happen, but when they are going to happen, they detect them well. Okay, so they work quite well. This is detection rate. This doesn't mean that this is going to happen. This means that they work well in predicting poor outcome. How does the ratio work? If we use them alone, as you can see, it has a much poorer performance. So what happens when we add it to the formula, and it's not improving amazingly, okay? It's not improving amazingly. As you can see, 88 versus 91, 87 versus 90. So when you add them, it's not improving impressively, but if we analyze, so that's that it has a lower prediction, that's the conclusion, and it has a small added value. But the thing is that when you take a look at how do they work individually, each of these 4 predictors, and we look with logistic regression and ask the statistics, are they independent predictors? The statistics say that they are independent predictions, so they all work well, and you should measure all four. Of course, if you don't have angiogenic factors, don't measure them, obviously, and you will do quite well, and you will be fairly doing well with these first three. But if you have the ratio, you can measure it. And the ratio works very well because, like the uterine artery, also it has a very nice association with preeclampsia. And that is a message that I think we have to keep in mind. When you have an abnormal ratio, it's not only telling you that this small baby has a higher risk and you should classify it as fetal growth restriction, but it's also telling you be careful because a preeclampsia could be around. So just keep a very careful eye on that case. So the summary is that they all have independent predictive value, and if you have the option, you could measure them all, and they work more or less in a similar manner. So you can do it this way if you have these three, but if you have the option of measuring the ratio or the placental growth factor less than 100, then in this case, it could be as well a reasonable way. And if you use our calculators, you will find that it gives you the option of introducing the value of the ratio. So it's an acceptable criterion to consider that a small baby is at high risk, and therefore that it should be defined as fetal growth restriction and not only as small for gestational age.
Its main value, it's a negative one, the negative predictive value, isn't it? Because whenever it's below 38, we can be pretty assured that we have an extra time to program the delivery, to plan the delivery.
So, that is true. That is true. But when you have another marker that is abnormal, so if everything is negative and angiogenic factors are very good, but for instance, let's imagine that you have very low CPR, even if the angiogenic factors are normal. What these studies tell you is be careful, because don't be falsely reassured. So if one of the factors is positive, then consider that this is a high risk. The other thing is when you're measuring angiogenic factors because you are concerned about preeclampsia. And in this case, a negative value is very, very reassuring that preeclampsia is not going to show up, at least for the next days and sometimes weeks.
So in practical terms, it could be applied in those cases meeting criteria for fetal growth restriction because of severe biometrical restriction below the third centile, and let's say the uterine artery Doppler, while in those cases meeting other criteria that we know that are more strongly associated with adverse outcome, it makes no clinical sense to be hurt by the angiogenic factor.
Yeah. So the summary is, do we think it makes sense to measure it? We think it makes sense because it's going to give you complementary information. It's going to tell you, well, yeah, this is a poor prognosis case, and definitely if you had reasons to believe you should go for, or you should recommend labor induction or delivery between 37 and 38, you have another reason. And the other very important thing you have to remember always, and we will be discussing a lot about that on Thursday, is that when you have a high ratio of angiogenic factors, be careful, because aside from fetal growth restriction, there is going, in most cases, or you already have a preeclampsia and you have not realized, preeclampsia is going to show her face soon. So that's an additional interesting information. Having said that, if you don't have the ratio, it's okay, and you can manage these fetuses with just ultrasound criteria.
Fine. Now we have two participants ready to ask their questions directly. So first one was John Jairo. Do you want to open your microphone?
Dr.
Good afternoon, Dr. Eduardo.
Hi, how are you?
Hello, nice to see you again. Fine, thank you.
And nice seeing you.
Now, my question is, if it's necessary to start to do a CPR normal weight, or because when the weight is in the limits, so it's necessary to do the Doppler or not?
Well, that's a very good question that you have asked to me, but I mean, we can answer both, and I think Francesc has probably ready some slides about the CPR. Just as a short introduction, I will say that for many years, we have been discussing about whether the CPR could be a good indication to identify these cases that we would call hidden growth restriction because they are in the centile 15, centile 20. You are concerned that they could be smaller, but you don't know whether there is any test. And the other issue is that sometimes, and for many years, people has been doing the CPR even in fetuses at centile 40 or 50, and then you find the CPR is abnormal, and you say, is that having any value? Should I do something, or is it meaningful to do this measure? And so that discussion has remained in the literature for 20 years. And I think we have some data that might not give the final answer because we never have final answers in life, but let's say get some light and bring us a little bit closer to the answer. And I think Francesc can share some slides probably now.
Yeah, okay, perfect then. Yeah, well, what it's clear is that an abnormal CPR, it's associated not only with an SGA baby and a severe SGA baby, as you can see here, for instance, that it's also associated independently of the fetal weight to severe neonatal morbidity. But you know that association is not the same than prediction. So the issue here is whether performing the cerebral placental ratio can further predict the occurrence of an adverse perinatal outcome. And for that, you must be aware of the ratio 37 study that has been recently published in the Lancet some 3 months ago, where precisely we tested the hypothesis that performing the cerebral placental ratio in the general population can have an impact in preventing some adverse outcomes. And let me share with you what happened with the cerebral placental ratio in each band of the estimated fetal weight. You can see here only in the arm that was concealed. So in the clinical arm of the study, where the cerebral placental ratio was not considered for a clinical decision. You can see here in red that there was only one baby that had an abnormal outcome among those below the 10th centile, and that is because in the concealed arm, also the estimated fetal weight was considered. So whenever a small baby was detected, labor induction was recommended. But looking what happened in those babies between the 10th and the 50th centile, you can see that 1/3 of the instances of adverse outcome, here in red, occurred in babies that had a cerebral placental ratio below the 5th centile. And the same happens actually in those babies between the 50 and the 70 centile. So the short answer to your question is that the cerebral placental ratio can identify some babies with an estimated fetal weight above the 10th centile that have an increased risk of adverse outcome. Here you can see the overall results of the ratio 37, where you can see that we failed to see an improvement in perinatal mortality, mainly because the study was underpowered. Even that almost 11,000 pregnancies were included, it was finally underpowered to detect an effect on perinatal mortality. But you can see here that there was an improvement in the neonatal morbidity, and you can see that that improvement can be quantified in a 40% reduction in the occurrence of severe neonatal morbidity. Put it in practical terms, John, you have to perform in the general population more than 350 screenings evaluating the cerebral placental ratio, of which we are going to induce about 20 women, that we can prevent by inducing these 20 women, one instance of adverse outcome. But as a warning for that, let me say that that only happens when you have the capacity to not to rush to the labor induction. You can see here which was the gestational age at delivery in those babies below the 5th centile. And you can see that even in those babies in the reveal group, it was only 7 days before, right? So the labor induction should be performed at 38 plus weeks. It's not a good idea to make a labor induction before that. If you don't have the capacity to plan the delivery until 38 weeks, it's not a good idea to start performing the CPR in your general population. Let me share with you one last slide where you can see among those babies that had a severe neonatal morbidity, that what happened here is that the time interval between the ultrasound and delivery was 5 days shorter in those in the reveal group. So if even by shortening such a small number of days, the delivery, such a good effect as that one can be expected.
So I think the summary is that, yes, if you measure the CPR in your population, you recommend delivery close to 38 weeks and not leave the pregnancy for spontaneous evolution, you should be able to reduce the instances of very severe adverse outcomes, which in the study were 7 every 1,000 babies and were reduced to 3 every 1,000 babies. That is almost or more or approximately half. So you could reduce the risk of a very serious adverse event to half in a population that has been classified as low risk. So we are talking about a pregnant woman that nobody considers her to be at high risk. And by measuring this ratio, you reduce by half the risk of having a baby with a very adverse outcome. Remember that in the study, adverse complication was considered to be very serious, with 10 days of admission in an intensive care unit, which is very uncommon in a normal pregnant woman at term. So what you are achieving by measuring the CPR is a reduction in the very unlikely possibility of having a very adverse outcome. And that's why you need so many inductions to do that. But you could reduce by half this risk. You are going to identify between 5 and 10% of your population at high risk. In this 5-10% of your population, you are going to do more inductions, and that is true, and that's a price we have to pay. But then you could be reducing by half the risk of severe complication. And I think that could be the answer we could give to our women, as long as we don't have any better evidence. But remember, this was a study in 10,000 patients, randomized, multinational study, and it's the best evidence we have so far.
What we are concerned about is that that should not be translated into a recommendation to deliver these babies before term. You should wait until term. And that's a essential message that we want to put forward here.
Yeah.
So you need some logistics.
Thanks for your question, John.
We have Hannah Eloso Bikova. She has been waiting here for a very long time. I hope she has not.
Hello, thank you very much.
Okay,
I would be happy to go a little bit back. You mentioned when you defined a group of high-risk women, we should be eligible for serial scanning to higher the pickup of growth restriction. You mentioned that those are has higher risk who have a positive first trimester screen for preeclampsia. And the other thing you mentioned was relative growth of BPD between first and second trimester. I have never heard about this. Sorry. What is it?
Good. We'll look at second trimester. The formulas that we have for estimated fetal weight collapses. So you need other biometrical criteria to pick up growth restriction. There are several biometrical criteria that you can use, but we recommend using the head measurements. And that is why it's a criterion for serial follow-up. If at second trimester you find reduced biometries, in particular regarding the head measurement.
Yeah, so but in summary, you can go to our calculators in the internet and you look for growth centile in the second trimester, and then the calculator asks you what was the first trimester BPD and what is the second trimester BPD, okay? You have had to measure the BPD in the first trimester, otherwise you cannot, okay? If you only measure the CRL, you don't have, you have to measure the BPD. So you put your BPD in the second trimester and in the first trimester, and the calculator tells you, okay, the growth has been within, should be expected, or this growth has been less. Okay, and when it's less than certain centile, it tells you this growth is below. I don't know whether we use 5th or 10th centile. I forgot that.
10th centile.
Centile. So you use 10th centile, and the machine tells you this growth is insufficient. That should be considered a risk factor that this baby is developing early onset fetal growth restriction. And there are several papers demonstrating this association. So it's not very well known, but it works very well.
Actually, rather than predicting fetal smallness, is diagnosing fetal smallness at second trimester.
Reality, yeah.
That is related to the diagnosis of fetal smallness at second trimester. And it follows that a baby that has been found to be small should be serially scanned.
Thank you very much. Thanks.
Thanks, Hannah, for your question. Regarding this topic of serial scanning for high-risk patients, we have 2 other questions that are very short ones, but I think they are worth mentioning. Why are we recommending 28, 32, and 36? Is it any benefit from doing it bi-weekly or in shorter intervals?
No, I think there is good evidence that you need to do your ultrasounds at least every 3 weeks in order to avoid false positives, and so certainly you should wait only 3 weeks, and then it makes sense to wait 4 weeks, which is the ideal interval in normal and in high risk patients as well. So if you do your ultrasound every week, you might find even puzzling findings. Sometimes you will find that the baby is smaller than the previous week if you change the operators, and would be very concerning because the mother will think that the baby is shrinking, which is not true, of course.
Okay, Francesc, and regarding the ratio 37 study that you mentioned, how many of the deceased fetuses in each group, reveal and conceal, had a ratio below the 5th centile?
Yeah, let me show it to you. That question has to do with the diagnostic performance. And I have here it prepared for you. Look, let's focus on the prediction of adverse neonatal outcome. Here you can see in the first 2 columns that the detection rate of an estimated fetal weight at 36 weeks below the 10th centile has a very low detection rate of adverse outcome. 10% of the babies are labeled as being small at 36 weeks.
You're sharing screen now, Francesc?
Let me check. Now I must be sharing it properly, right? Here, these 2 first columns, you can see here in blue that the detection rate of an estimated fetal weight below the 10th centile, actually it's very low. It's even below 5% for adverse neonatal outcome, right? It's much better when your aim is to detect a small baby. But here we are trying to predict those babies that are destined to have a very severe adverse neonatal outcome. 10% of the babies are labeled as being below the 10th centile. Regarding the CPR, use on a standalone, here it says the 10th centile, but it should say the 5th centile. it's about 3-4% of the population that has a several percentile ratio below the third centile. You can see here that the detection rate is much improved. We have to admit that is not a good detection rate, but that happens with many other conditions, and you can see that at least it's 5 times higher than the current standard, that is the estimated fetal weight. And you can see here that when you combine both, the detection rate, it's only marginally improved. About 10% of the babies meet the criteria of having an estimated fetal weight below the 10th centile or a several percentile ratio below the 5th centile. So the answer to your question is that 10% of the babies would be labeled as high risk.
Well, if you use centile 5, you should find around 5. If notice that the centile is not well applied, but it's never perfectly 5. Could be.
Yeah, but 5 is the general population, and here we are dealing with low risk pregnancies.
Yeah.
Why it's a little bit lower.
A little bit less.
Yeah.
Okay, but I think the question was regarding the fetuses that suffer from an intrauterine fetal demise. Like all of them have CPR below the 5th centile, or they don't?
That's all. Well, here in the definition of adverse neonatal outcome, of course, there is also the fetal death, but we only had a very few cases of fetal death. But the experience tells us that only a small proportion of babies have an abnormal CPR. But what happens here and what's interesting is that proportion is much higher than the proportion of babies ending with a fetal death that are below the 10th centile. So at least the CPR can pick up some babies, not all, but some babies that are destined to have a fetal death.
Yeah, I think the problem is when you look at the way of you start sub-analyzing data and you start asking a lot of complicated questions, it's difficult to understand. I mean, the question of the study was very clear. I mean, if we measure the CPR in a whole population of low-risk pregnancies, can we improve the outcomes? And the answer was yes, very clearly. And that's what it was published in the Lancet, and that's the answer. And then, of course, babies died because of many other reasons. One clear thing that came up of this study is that the study was underpowered to detect changes in mortality, because you would need a population probably of 50 or 100,000 because mortality is very low. But mortality was very clearly reduced. And you're going to find cases of all types, cases where the Dopplers are horrible and the outcome is good, and cases where everything was perfect and the baby had a horrible outcome. But some babies which have a horrible outcome, and we're talking here of non-neurological morbidity, neurologic morbidity, which was not significant, but was also reduced, and overall morbidity, we're talking about very serious complications that were very uncommon, as I said, 7 in 1,000, and were reduced to half. And this is those cases that probably are related with placental insufficiency. Then there are other adverse outcomes that are not related with placental insufficiency, like complications during labor or many other reasons, or too long labor or dystocia or whatever you might think of. So in general, in a low-risk population, is it worthwhile measuring the CPR, or you are going to do more harm than good? The results suggest that you do more good than harm. And that's, I mean, the summary. And I think what you should take back. Of course, as long as you do it well, don't induce labor before term. If a patient has CPR that is low, don't get hysterical and do an induction overnight. You just wait until as close as possible to 38 weeks, and then at 38 weeks, you recommend delivering instead of waiting for a spontaneous start of delivery. And then these results done in almost 10,000 patients showed that you do more good than harm. And that's the best evidence we have. We don't have any other study similar to that.
And one strong point of these findings is that they are a pragmatic trial. I mean, the study captures a real setting. For instance, in 1/3 of the cases with an abnormal CPR, women were not convinced for labor induction, or were convinced only several weeks after the finding of abnormal CPR. And that is what's happening in a clinical practice. Even taking into account these limitations, that in real practice, not all patients are convinced by our arguments, you can see that there is a benefit here when you apply it in an ordered way.
Okay, so just one more question.
We have
and we'll
a last
for us
question,
to-
right? From Jasan.
Yeah, he's ready.
Hi.
Yes,
Hi, good evening.
Hi, how are
Uh,
you?
th- Fine, thank you. Thank you very much. Just my question regarding, we saw every day that when the baby was appropriate for gestational age, normal Doppler, normal CPR, everything is okay, but regarding the abdominal circumference is less than third centile. Is there any rule regarding induction of labor or when to deliver baby with abdominal circumference less than third centile, and after exclusion other pathological regarding the baby?
Yeah, so your question is if you have a baby where everything is normal and it's a
Yes.
third baby, I guess, and the abdominal
Yes.
circumference is less than the third centile, and the rest
Mhm.
parameters are normal, and the estimated fetal weight is okay. It's above
Yes.
the 10th. I would say that could happen. It's not very common, but might happen but what would you suggest in this case, Frances?
No, what I suggest is not to look at the abdominal circumference and alone, because look what is happening here. That was the starting hypothesis of this study that you can see here, that only taking into account the estimated fetal weight or combining it with the abdominal circumference. And you can see that combining both of them is not followed by any improvement in the detection rate of a small baby. So it's not a good idea to take into account the abdominal circumference as an standalone. Another different question would be if you can use the abdominal circumference instead of the estimated fetal weight.
Mhm.
Arguments to use the abdominal circumference instead of the estimated fetal weight. But if you go for the estimated fetal weight as your diagnostic criterion for suspected SGA, don't look at isolated parameters such as the abdominal circumference, because it's not followed by any clinical benefit.
No, my recommendation, if you have a very uncommon case where the estimated fetal weight is normal and the abdominal circumference is below the third centile, which is really very small, well, the first thing I would do, certainly, and of course, if you have had such cases, of course, I guess you've done that, but I would very, very carefully see whether there is any reason that explains this asymmetry in a baby, because that's a big asymmetry. So if the estimated fetal weight is, let's say, it's 20 and the abdominal circumference is less than 3, I would certainly go on whether there is a congenital diaphragmatic hernia or whether there is something I have missed, because that's rare. It's rare. Okay, everything can happen, and you can always have exceptional cases. But in general, I mean, I would take a look at and then you have one of these very, very weird cases. You can find nothing, and well, probably this is such an exceptional case that just for the sake of precaution, you might want to consider to deliver this woman at 39 weeks, maybe, but just because that's what you do with exceptional cases that you don't understand. We all the time have cases we don't understand, okay? But I would say that should happen to you very, very uncommonly. And maybe Frances wants to play that with some data.
Well, no, here it's summarized the arguments that we have to advocate for the estimated fetal weight instead of for the abdominal circumference. Well, one strong argument is that there is a much larger number of curves to select for the estimated fetal weight than for the abdominal circumference. It's much more easy to find the curves that apply to your population for the estimated fetal weight. And also another important issue is that it allows a smooth transition from the fetal to the neonatal life, because the neonates are going to be evaluated by the birth weight, not by the abdominal circumference.
Yes, you're right.
A more consistent measurement before and after delivery.
So we would say we only use it below 24 or 20 weeks when we don't have good formulas for estimated fetal weight. But if not, we don't really look at it unless it's exceptionally small, and then we are concerned about an intrinsic problem in the baby.
Thank you very much.
Thanks for your question.
Thank you.
So now we will go for a short break that you can grab a coffee or something, and we will solve the technical connection problems that we had, and we will go for the Doppler evaluation.
Okay, so let's take 5 minutes, but it's 17 now. Whatever your hour is 17 and a half. So let's meet at 25, and we will start sharp this time. Thank you very much.
Hi, welcome back. I hope you're ready after this short break because we want to profit our time. We have ready the Doppler evaluation on real time with Dr. Eva Meller. So she will be joining us.
In the meantime, Leticia, let's address some of the questions that are arising.
It's a pity because we don't have the previous questions. So those that have asked something and you didn't get an answer, you can write it again in the questions and answer chat. Sorry for that, but I can't have them now.
In that case, let me discuss something that Duarte touched on, that is the occurrence of fetal restriction with preeclampsia altogether. And one common question, Eduard, that we are made is that what should dictate our management, the preeclampsia or the fetal growth restriction?
Yeah, that's a common question we have, and we always have the same answer. And is that you should consider this as a patient that has two diseases, and you follow the HCCs with each protocol, with one protocol. So, and you listen to both protocols, and if both protocols are telling you, okay, you can wait, then just wait. And some cases, preeclampsia will be more severe. And then in these cases, then you follow the advice of preeclampsia protocol. So sometimes you will have a severe preeclampsia at 32 weeks, and then you will look at the stage of fetal growth restriction, and the stage will be 1. And so preeclampsia protocol will say this is severe preeclampsia with severity criteria. You have to deliver at 32, and the baby is still okay. Okay, but preeclampsia says we have to deliver, and the same and the other way around. Sometimes you will have a patient with a preeclampsia with no severe features at 34 weeks, but the baby has absent end-diastolic velocity. You have to deliver because the baby otherwise is going to develop a complication. I think it's not complicated. You have to follow both protocols. You can apply some simple rules, like if you have a preeclampsia, you consider that the baby is at a later stage of severity, but I think it's easy to follow two protocols. It's a very common situation in early onsets. You are going to have preeclampsia in half of your cases. It's going to be rare in late cases because you have preeclampsia in about 10-15% of cases. So, but especially in early onsets, that's something you have to keep in mind always. Preeclampsia is there. There are going to be a lot of cases that are complicated with preeclampsia, and so never forget that preeclampsia is a very common companion of early onset fetal growth restriction.
That is good. Leti, any emerging question?
We have a question that I don't know if we will be commenting that on the Doppler evaluation. I think we won't, about the aortic isthmus. But are we recommended to perform the evaluation of the aortic isthmus right now or not anymore?
Well, that's also a very common question, because you know that in former classifications that we had, the reversed end-diastolic velocity in the aortic isthmus was one of the criteria for stage 2, and in the latest upgrade of that staging criteria, it fell, and it fell mainly because of this that you can see here. Let me share with you that screen, and can you confirm me that you are seeing my screen?
Yeah, we are.
Well, you can see that it happens that about 25% of the babies with an early onset fetal growth restriction have a reversed end-diastolic velocity in the aortic isthmus, but almost all of them also have an absent end-diastolic velocity in the umbilical artery Doppler. And that means that for the vast majority of cases, the umbilical artery Doppler makes the job of identifying severe placental insufficiency. And that is why it's no longer a criterion for stage 2 fetal restriction. However, having said that, if you are competent enough to perform an aortic isthmus, it's a good vessel to be performed. mainly because it becomes abnormal a little bit earlier than the presence of the absent end diastolic velocity. But the clinical gain, it's rather small. That it's why it's not recommended to the overall of the practitioners, but for those that are competent, it's a good vessel to evaluate.
Thank you, Frances, for the answer. They are also asking about the use of CTG and also about computerized CTG, both types that are recommended in fetal growth restriction in every case, or depends on the gestational age. What's our opinion on that?
No, well, it's not a matter of opinion. It's a matter of what do we use in our protocol. And sorry, I wanted to share screen and I clicked the wrong button. So I'm going to project here one of the typical slides with our stages, and what is the role of computerized CTG? Computerized CTG is really a software that you couple with your CTG, and then it gives you what they call the short-term variation, and it's given in milliseconds. So if it's less than 3, then normally you consider that it is abnormal, and depending on gestational age, it can be less than 2.5, and you have that in the instructions of the software. So when the software says, okay, can be pathological, then the computerized CTG has a very similar predictive performance as an abnormal ductus venosus. And when I say abnormal, it's not just elevated pulsatility, but it is negative atrial flow. Okay, so absent or reverse atrial flow. So when you have absent or reverse atrial flow in the ductus, you know that you are in the terminal phase of a fetus with growth restriction. If you're doing computerized CTG, it has an equivalent value. Okay, we don't put a lot of stress on CCTG, on computerized CTG, because it is not available. It is actually an European thing. Okay, you don't find it in the United States, not in Latin America, not in many countries in Asia, not in India. Most of these places you will not find computerized CTG, but if you can incorporate it, it's going to be useful because it's a software and you can use it. Okay, so you could use the protocol without the computerized CTG. The classical or the conventional CTG, the cardiotocography that you take a look at, is what we really, let's say, recommend for being used in fetal growth restriction monitoring. It is useful at any time that you're doing a measurement with this patient. Every time you're doing follow-up, it makes sense to do a CTG, but it takes most of its value, especially as you go from stage 2, 3, and 4. As the baby gets into a more severe condition, the CTG is valuable, particularly in the very late phases. So the best recommendation is to combine the ductus with the CTG every time that you're looking at this patient, the ductus and the umbilical artery, of course. And the CTG essentially is going to identify unexpected deterioration. So even if we say, if you have a patient with absent or reverse atrial flow, and you should have it between 4 and 7 days before the final deterioration, you might have some cases where the baby unexpectedly deteriorates. I would say in many of these cases is because there is a preeclampsia associated, but this is going to be best identified by CTG, and therefore, for sure, you should use conventional cardiotocography in the monitoring of small babies. If you have computerized, it's okay, but computerized, it's going to be useful as an equivalent of ductus. And this is the summary.
On this issue, Eduardo, I always show this slide that you can see here, that, well, the evidence regarding the computerized CTG, you know, that comes from the TRAFEL study that compared the combination of the ductus venosus and the CTG versus CTG alone, right? And here you can see the results in the group of ductus venosus plus CTG. You can see here that in most cases, the delivery was dictated by the CTG. In 40% of the cases, it was dictated by the CTG and only in 20%, 22, it was dictated by an abnormal ductus venosus. But if we look into those babies in which the delivery was indicated by the CTG, you can see here that in the vast majority of cases, it was because of decelerations. Only in 7% of the cases, the only criterion was the reduced short-term variability on the CTG. So the bottom line of it is that if you don't have a computerized CTG, well, you are not performing it optimally, but you are performing it 93% well. So go for the conventional CTG if you don't have such technology.
So, I mean, if you could do your perfect, I mean, if you could follow up your babies perfectly, then the best thing would be to do a ductus venosus every day when you are in stage 3 onwards. Okay? So, this is a comment that we very often make, because I think it is a little bit confusing that when you are having a baby in stage 3, that means that this baby has reverse end-diastolic flow, then this baby should be followed every day, okay? And it's going to have a high association with preeclampsia. So you have to keep these things in mind. This is a very severe case, and you need to follow this patient every day, okay? And you have to remember that this baby can be okay, but you don't know whether it's going to be okay in 12 hours or in 24 hours. So it's like an ICU patient. It's a patient that is in an intensive care unit, but unfortunately we cannot monitor it because it's a baby, it's a fetus that it is inside the mother, okay? So if you could monitor this baby in the optimal way, you should do Doppler and CTG every day, at least, okay? What happens in many places in the world is that you can do Doppler some days, but not all days. Even in large hospitals, ductus venosus is not doable every day because they don't have the expertise, they don't have, then the weekend comes or whatever, okay? And that is what happened in the truffle study. When you read carefully the methodology, they tell you that they did the ductus venosus when they could, and it was done in a range that was ranging from 1 day to 1 week, okay? So if you don't measure in the ductus every day, it's especially important to do CTG every day, because this patient is really sick. This fetus could die at any moment. So you have to combine both. And it is not surprising that you will find cases in which you say, okay, the ductus was normal, and then the CTG started having some decelerations. But because your ductus was done here on Monday, and you stayed 3 days without doing more ductus, and then on the 3rd day, then the CTG started decelerating. Of course, this is not meaning that the ductus is not working well. It's meaning that the ductus works for 24 hours, not for a longer time, okay? So that's very important to remember. And that's why the CTG, which is available, you can do it in many places, in all places in the world, then it's certainly very important. So, but remember, when you can, just do Dopplers every day, and that should be the optimal. And when you cannot, okay, do what you can, but then of course, don't expect the results to be as optimal. But it's an acceptable way of following these babies, of course.
Thanks, Eduardo. I think that was super clarifying. We have 2 participants ready to ask directly to you. One is Kirti Girish, that I see your camera on as well. So go ahead with your question.
Hello, sir. I just wanted to know, how should we manage FGR diagnosed early in 2nd trimester? And if the mother wants termination of pregnancy, how do we counsel her as to when should she decide to just continue the pregnancy, and how to decide whether she should go for an abortion?
Yeah,
or we can just follow up?
Yeah, you mean you have a very early growth restricted baby, and
Yes.
then you have doubts. Well, here I would say that there is the first caveat is that there is a subgroup of cases that are very early, that appear at less than 25 weeks, and this is what we should call 2nd trimester fetal growth restricted babies, the prevalence of placental insufficiency in these babies is much lower than in later babies. We have some studies, and Francesc has published some very nice studies showing that the prevalence of genetic problems is very high in these patients. So that should be a particular subset of cases you should keep in mind. Okay, but then let's focus on the patient that, let's imagine that you have done your ultrasounds, you have done your genetic test, and the Dopplers are abnormal, and you say this is really, or most likely, a placental fetal growth restriction. And now we are 24, 25, or sometimes even 26. We have reversed everything. We have reversed umbilical artery. We have reversed ductus venosus. What should be the counseling in these patients? And certainly, we consider termination of pregnancy in very severe cases. That is a sensitive issue, and it can change from country to country. So in some countries, that could be something that you cannot even consider to discuss, and some other countries you could. And I don't think we have a perfect answer for that, but I would say that when you have a very severe case at less than 26 weeks, if you look at the mortality rates, they are exceedingly high. They are exceedingly high. The sequelae rates are exceedingly high, and therefore, I mean, that is a very reasonable discussion to have, and I don't think we have a perfect answer. I would look at the literature and discuss with parents, but I would tell you that in our setting, we consider that in extreme cases, yes.
Let me add,
yes,
let me add something here. And first, let's make a clear cut between the second trimester and before 26 weeks and after 26 weeks. After 26 weeks, other parameters than the gestational age and the estimated fetal weight should be taken into account in counseling, because as you can see here, the use of magnesium sulfate, the fetal sex, and also the Doppler status, they are contributors to mortality or severe neurological morbidity. And in counseling these women, you should combine all these factors here. And only to illustrate this point, let me share with you two clinical cases. That's a girl with an absent end diastolic velocity in the umbilical under magnesium sulfate at 27 weeks with an estimated fetal weight of 700. And as you can see here, that girl has an 80% of likelihood of survival without major sequela, while if the clinical case is a boy with a reversed, not absent, but reversed end diastolic velocity in the umbilical with magnesium sulfate at the same gestational age, but with an estimated fetal weight of 600 instead of 700, you can see here that the likelihood of survival without major sequela is below 40%. And by illustrating these two different clinical cases, what I meant is that you should take into account in your counseling all these clinical factors that can make a difference in survival without major sequela, and use them in counseling these women.
Yeah, if you want a very simplistic, Francesc has very nicely illustrated that you can refine this calculation very much. But something, I mean, of course, we are not in favor of recommending termination to patients. But something that really needs to be kept in mind is that there is a huge difference between the risks that you can have calculated for preterm babies at a given gestational age, and when this baby has fetal growth restriction, it's going to increase very much, particularly below 28, 27 weeks. After 28 weeks, it's going to be very similar, okay? But below, if you have data from your hospital that say these babies have, I don't know, 25% risks if it's fetal growth restriction, it's going to be double, and that has been documented in several studies. And maybe you were going to say something like that, Francesc?
Yeah, regarding the other scenario that was put forward, those babies that are diagnosed at second trimester, and by that I mean before 26 weeks, so before viability. And you can see that at diagnosis, the presence of an absent or reversed end diastolic velocity in the umbilical artery Doppler can make a good job in predicting those that are going to have a very adverse outcome. So if termination of pregnancy is an option in your setting, you can use it at diagnosis of fetal growth restriction to counsel women regarding their risks with ongoing pregnancy.
Let me show you what I was saying with the slides as well. These are data that have been published, and they are very similar to data that we have at our institution that we have not published. And as you can see, this is the mortality of when you have an appropriate for gestational age. That of course the mortality goes up as you go down in gestational age, but look at what happens when you have a small baby, okay? So this really changes. Look at 25, 26 weeks, these differences are significant. And why would you consider to deliver a baby here at 26? Because you have abnormal Dopplers, otherwise you would not. So if you want to remember something very easy, just remember that in general, mortality doubles for these babies, and the rate of severe sequelae also doubles. So certainly below 26 and 25, the numbers are very bad. And after, it is reasonable that we are talking about termination, but there is another option. And the other option is to say, okay, we are at 26 weeks. In our hospital, we can offer you 50% survival with our neonatological care. So if you have growth restriction, this will go probably to a much higher mortality. Let's wait until 28. And if we arrive at 28, good. And if not, if the baby dies, that's okay. That's sometimes more acceptable to parents, okay, rather than doing a termination, which sometimes can be very, it's not that we forget, but it's important not to forget that that is a terribly traumatic decision for a pregnant woman and for the parents to decide to do a termination. So one other option that we also use is, okay, the situation is not good at all, but we know that by waiting until 28, we might improve things because the baby will be more mature. We have the risk that this baby could die, but because the results are going to be so bad, let's wait until 28. And then if we arrive at 28, we will deliver. That's an alternative. Okay? Both are acceptable. But having these numbers at hand is certainly important, and you will do good to your patients by counseling them. It's very, as I said, traumatic for them, but I think the more informed decisions and better decisions could sometimes be made.
Thanks for.
Thank you.
And we have another participant ready. That is Geetha. I don't know if I'm pronouncing it correctly, but I hope she can see or he can hear us. Okay, if not, I will say.
Let's give another option after another question.
Yeah.
And if Dr. Tampiraya can switch on, then in the meantime, then we get back to him or her.
Okay. So they were asking, in the second trimester, are we using BPD or circumference, head circumference to date the pregnancy? What is the best parameter?
We don't know which is the best parameter. What we know is that we are using the BPD because that is what we have standards for. So the BPD, it's an option, and it's the option that we have. I'm not aware of any curves regarding the longitudinal progression of the head circumference. For that reason, we use the BPD.
Sorry, you were talking about CTG before. When is the earliest time to perform a CTG?
Yeah, well, that's a very good question. And if you look at classical books that were published when I say we, Francesca and myself, and some of the audience, not the others, for which it could be prehistory. when we were young, a book said, I mean, you should do a CTG after 32, 34 weeks. Why? Because the CTG in theory is measuring, especially when you're doing a non-stress test, okay? CTG, just remember, it derives from originally the test that was done during labor to see whether there was fetal distress during labor. And then it was moved to outside labor, and that's why it was called non-stress test, okay? Because you are theoretically doing this test in a non-stressful situation. And therefore, at that time, essentially what you're looking at is the variability, essentially. And the variability is most or best determined after 32, 34 weeks when your basal ganglia that regulate the sympathetic and the parasympathetic regulation of the fetal heart rate then are acting, and then they determine this variability, okay? If you go very early, you could find a baby that is too immature, and you could find there is no variability. So the use of CTG gets more and more difficult as the baby gets more preterm. You have to add that sometimes we're giving medications like magnesium, sometimes beta blockers. I mean, that could also have some interference. So you should be very careful in interpreting the variability in very preterm babies. But something that works very well at any gestational age is decelerations. Okay? So when a baby is showing decelerations, and particularly what we call spontaneous decelerations, that decelerations in the absence of any uterine contraction, then you should consider that this is a very serious situation. That is what is seen in these very early onset fetal growth restricted babies. So I would say that when it's a very early onset, then the CTG is very useful, but then because you are looking for decelerations or very, very, very terrible patterns, and when it's late onset, then you are looking at other things. You're looking at variability and maybe decelerations, but in response to contraction. So there are two ways of interpreting it, but it's useful in babies that have a disease. Don't do a CTG in a normal baby because you are going at 28 weeks, because you're going to find all sorts of things that you don't understand. But when you're looking at an early onset baby, it makes sense. But essentially, you are looking at decelerations in these very early onsets.
But let me add here, Eduard, that it doesn't make a criterion for delivery an isolated deceleration. That does not make a pattern as decelerative. We have to have repeated deceleration.
That's an important point. That's an important point. If you read the protocol, you will say it says persistent deceleration, not just one single, of course.
Yeah, okay.
And also remember that very preterm babies have spontaneous decelerations as part of their normal physiology. Okay, so one deceleration without any, okay, and the baby continues normal, okay, that could be physiological even, all right? But persistent deceleration, this is a very pathological finding.
Yeah, more than 2 each 10 minutes during more than 30 minutes.
Mm-hmm.
Fine. I don't know if this doctor that we mentioned before, Geetha, are you okay? Yeah?
Sorry.
Hi.
Welcome.
Now we can hear you.
Yeah, hi. I would just
Hi,
like to
if we could
have a
hear you, it would be fantastic. But I mean, if you cannot, let's keep up with him.
Okay, let me see if I can let you see me. Where do I go?
No,
Oh,
we will tolerate it, but if you can, that would be good.
oh, okay, over here.
Great.
Yes.
Hi.
Hi.
I would like to have some clarification about the last lecture, where about the management, about the Bishop's course, and how do you decide for a stage 1 fetus? That part wasn't very clear to me, the Bishop's score and the CPR.
Yeah. Okay, that was a comment, and to clarify a little bit the mode of delivery in these babies, that you're referring to this slide probably, okay?
Oh.
Yeah, that should be that. I mean, how should we decide the mode of delivery? And I will come to the Bishop and to the CPR now, okay? But the starting question is, okay, I have a fetus with fetal growth restriction. How should I consider the way of delivering this baby? When you have stage 2 to 4, when you have absent end diastolic velocity or worse, after 2 contractions,
recording stopped,
will deteriorate substantially. So of course, by definition, you should do cesarean section. So the question comes when you have stage 1, okay? When you have stage 1, you have a baby that is small because it has a very low estimated fetal weight, because it has an abnormal CPR, because it has abnormal uterine artery, or even, as we said before, because it has abnormal angiogenic factors. How could you manage this patient? And we don't have a single answer, but the short answer is that depends of how is the baby and how is the expected labor. So if you're expecting a very difficult labor, and if the baby you consider that is not in perfect shape, you look at how long the labor looks by looking at the Bishop score, okay? And you look at how the baby is by looking at the CPR. The CPR is a measure of the sort of degree of baseline hypoxic conditions or fetal reserve, okay? So if the Bishop is very unfavorable and the CPR is abnormal, if both are abnormal, the risk of cesarean section for fetal distress is quite high. This is the risk of cesarean section, of emergency cesarean section, okay? It's not the overall risk of cesarean section. This means that you have a quite high risk of rushing, all right? If the Bishop is very favorable and the CPR is good, the risk is 10%, which is maybe a little bit higher, but very similar to a general population, okay? And if the Bishop is if you have at least one of the
recording in progress,
at least one of the two, then you have 20%. So it's more or less in the middle, okay? So when you have a patient with fetal growth restriction stage 1, you certainly have to look, how is this labor presenting? Do we think that labor will be very difficult? And you look at the Bishop, and if the Bishop is very small, this means that you have a lot of dilatation ahead and a lot of contractions ahead. So it's going to be a long labor, okay? And if the CPR is low, then you say, okay, this baby probably has some degree of hypoxia and it's going to show a low toleration to contractions. So when both are present, doesn't mean that in all cases it's going to happen, but you have a much higher risk of cesarean section. So you could use this table to counsel your patients. If you are living in a country where you are doing 90% of cesarean sections, of course, this is not a table that you want to pull up, okay? Don't complicate your life. But if you really want to offer the possibility of vaginal delivery, this combination of factors predicts quite well, okay? The other thing that you should consider is that once you start inducing labor in these patients, then you would be better off by offering a mechanic way, like Foley, or the balloon that is offered by Cook, okay? If you are using a Foley balloon, it's not that we have big randomized trials, but the evidence suggests that it is much better, okay? I hope I clarified a little bit, but
yes,
let's see.
You did. Thank you. But the last question, the mechanical then should be used for even for the poor Bishop score? And also for the last category where the risk of cesarean section is only 10%, for all of it, it's better to use mechanical?
I mean, the first table is what you should discuss with your patients, okay? And so you should say, okay, you look, I mean, something happens to us here very often in European countries is that we have patients that are very willing, very eager to have a vaginal delivery, okay? And it's happening more and more often in other parts of the world, okay? So in these patients, you discuss and say, okay, but due to your conditions, labor is going to be long, and this baby is not perfect. So we have in half of cases, we're going to rush. We're going to have to rush to an operating room. And so that is something that you should take into consideration, okay? Once you have decided to go for labor induction, you use a mechanical method in case you need to use it. Of course, if this patient is 5 centimeters dilated and it has a half a face cervix, you will probably go for oxytocin directly. But if you consider that there is a need for cervical ripening, it is much better to use a mechanical method.
Okay, thank you.
Now, Frances wanted to show these results.
Or just supporting your statement by this meta-analysis of observational studies.
Yeah, so when you are using mechanical ways, you reduce, as you can see, as you can see in this slide, the risk of adverse intrapartum outcome and cesarean section for non-reassuring fetal status. And you also reduce, very importantly, the risk of emergency cesarean section. That is something that needs to be discussed with some patients. I mean, it's not that we will do a cesarean section, it's that sometimes we will have to rush very much. And as some studies have shown, when you have to rush, which is obvious, your results are going to be worse. I mean, it's not the same to say, okay, let's do a cesarean section because we don't see things clear, than to say, okay, let's rush because this baby is showing horrible decelerations and we are trying to stop contractions, but let's rush cesarean. Okay, the results are not the same. So it's just something that needs to be decided. And today we're moving into a medicine that is very much reaching a consensus with patients' wishes. So we need to explain them well, which are the probabilities, and we are not the ones who decide anymore. I mean, we need to go into a consensus with the mother and with the partner, but these data can be helpful.
Thank you. Thank you so much. That was very clear.
I think the live demonstration is ready.
Yeah, but I think we have one person waiting, Dr. Abdelaziz, so we might have his last question and then move to the demo, okay?
Doctor, are you able to hear us now? Dr. Hebataya? If not, we will switch to the real-time demonstration, right?
Okay, let's try later, not to keep everybody waiting. I think for whatever reason. The question was clear.
Okay.
Dr. Abdelaziz has said, so okay, thank you very much. So I think we could try to connect now.
Yes.
If it's coming up.
Okay. Okay, yes. Can you hear me?
Yes.
Yeah.
Hi, good afternoon.
And you can listen to us, Eva?
Sorry?
Can you listen to us?
Yes, perfectly.
Okay, so we have Dr. Eva Meller. She's a senior consultant at our maternal fetal medicine department at BC Natal. And she's going to do the demo.
Yes.
And so we can start with the Dopplers, and maybe Frances, you want to guide which vessels should we be taking a look at, and we have a nice view of Eva now.
Yeah, we can start over with uterine artery Doppler, Eva.
Okay. So I will introduce you Maria and her baby Munib. Okay, so let's do the uterine artery. So we are in the middle line. Okay, we move towards the right, the patient. Okay. So we can see here into the black and white the arteries, iliac arteries. Can you see it?
Yeah,
very
perfect.
well. So
Okay.
you have located the iliac vessels first in black and white,
Yes.
and by a slight movement.
Okay, yes. Here you can see.
You know
Just
that
here?
the uterine
Okay.
artery is going to be there. You switch the Doppler on, and you know that the uterine artery is going to be there.
Yes. Then to find the uterine artery, we need to bend a bit the probe towards the belly of the mother in order to improve the angle.
Eva, tilting it towards the patient feet.
Sorry?
Tilting it towards the patient feet.
Yes.
Feet.
Yeah.
And
Just here.
let me stress here when we should start the Doppler the color evaluation. You showed us a plane where you can still see the uterus and you the pelvic vessels. Can you switch off the color for a sec?
Yes.
That is where we have to start our evaluation. In that plane that you can see a portion of the uterus, but the pelvic vessels, and that's the more efficient plane to start with.
In fact, we can see the uterine artery, no?
Yeah.
Just here.
Yeah, in that particular case, very easy to
Yes.
find. But even in those more difficult cases, that's a good starting point.
Yeah. So I just put on the Doppler again, the color. Now we have optimized already the scale, but we need to optimize the gain. Yeah. Just here. Okay. We tilt the probe.
So you're expecting to find very high velocities, so you move your scale of the color at high velocities, right?
Yes. Right. As you can see, we are 70 centimeters per second. And now we're gonna we need to improve
that Eva's insonating the vessel just below the crossover with the pelvic vessels.
I think what's a little bit confusing for the audience is that the colors are inverted in this ultrasound. I think it could be better if we put the colors in the usual.
Just here.
So
yeah, much better.
Okay, that's the normal direction.
Yes, and as you have seen, if we just insonate in that place, we will see the iliac vessels too. Yes. See. So we need, as Dr. Figueras has said, just go a bit down.
We have a little aliasing because the velocities are so high that the machine gets crazy and shows you the opposite color. And that's what happens when you're measuring very high velocities and your scale is high, but it's not covering the velocity. We should find a very high velocity in this case. You can see it's more than 100.
Yeah. You have optimized. I don't.
That one is an interesting signal, because you can see here two vessels, one branch, not now.
Not now. But I'm gonna try to
rated how we can make a mistake and obtain a cervical vessel instead of the uterine artery Doppler.
Oops. Yes, we just come back. Just here. Yeah, maybe that one. Yes, Francesc. Maybe here. Okay.
Well, in that particular case, it's almost impossible to make a mistake because it's so clear the uterine artery Doppler, but sometimes it can be confusing. That one is perfect.
Mm-hmm. If you want, we can just go to the other side.
Yeah.
Good.
To see if it's as good as that one.
And let me insist on your hand movements, because you started from the midline, right?
Yes, from here. Can you see my hand? Not really?
Not well, not with a proper zoom, but we can see it. And now you are moving laterally.
Okay, I'm just going to the left side, okay?
Right, okay. Until you find that plane that we mentioned that it was the ideal to start with, that one, okay, where you can see the uterus, but also the pelvic vessels. And here it's where you start the Doppler insonation, the Doppler evaluation, that plane
here.
Here.
The pelvic vessels.
And then you tilt your hand, aiming to the patient feet to improve the angle, as you have done here.
Yes. And now we need to optimize the scale, the gain of the vessels. Don't know if we can just go high. No, maybe after, yeah. Okay.
It is not very uncommon that in advanced pregnancies, one of the sites is easier, or let's put it in the other way, one of the sites is more difficult than the other. That's correct?
Yes, that's correct. And in fact, the other patient we have, if we have time, we can show you, because the other patient has several myomas. And we have been just trying to get the uterine artery, and it's not so easy as Maria. So we can see whether the place where we should just find the uterine artery is quite different.
Here it's also well illustrated that the crossover of the uterine artery Doppler with the pelvic vessels is not an anatomical crossover.
Yes.
An ultrasound crossover, and that is why you can see here the uterine artery Doppler without the pelvic vessels.
Yeah, and the pelvic vessels are here.
Are here. Not in the same anatomical plane.
Yes. So we're gonna just.
So this we can have a good image, but it's not as nice anatomically as the other one, probably because you have
Yes.
the anatomy is a little bit more difficult.
Perdón. Yes.
Again, we are expecting very high velocities here.
That's it.
And this difference in velocity should have any meaning, Frances? So could it reflect the placental position?
Yeah, well, yeah, the vessel that corresponds with the placental insertion always has a lower pulsatility, but is not reflecting any clinical issue. Both of them should always be evaluated, and the average of both should be considered for clinical purposes.
Yeah.
Mm-hmm.
And that's not the case that we're going to find here, but if there was a notch, would we take the notch into consideration for the interpretation?
Well, it's the same. The notch does not add any clinical value to the PI. So we use the pulsatility index, but not the notch.
Okay, so you have a case like this one, which has a huge velocity in systolic phase and a huge velocity in diastole. This means that the adaptation of the uterus, the vascular adaptation has been perfect in this pregnancy. Of course, you measure your pulsatility index, that is going to be low. And even if you see a notch, don't pay any attention to the notch. If the pulsatility index is okay, this is okay, right? And that's very important.
Yeah, the notch, it's maybe rather subjective, because look at the first wave that we have.
Yes, exactly.
One say that there is a notch here, and also it happens in the fifth.
Maybe that one, yeah.
That one. So sometimes it's very difficult to see that or to agree on that notch. So forget about it. Use only the pulsatility index.
Mm-hmm.
Leticia, if there is any question
Yeah,
concerning,
we're adding other vessels, but we will wait for that evaluation, I think.
but if there's anything coming up, I think we could move to other vessels. I think has been very clear now.
Right.
Okay. The umbilical, maybe, or
Press the umbilical, yeah.
okay.
You are looking for a free loop.
Free loop, yeah. I'm trying to try to see both umbilical arteries in order, just in case I have an abnormal umbilical artery, just check the other one.
First thing, they were asking if we should determine the umbilical artery in a free loop or next to the.
Yes, always in a free loop. Okay.
It's where.
Why should we measure it in the free loop?
Well, one reason is that the curves that are published were made on the free loop, and it happens that near to the fetal insertion, the PI it's always higher, so it's more pulsatile, and it takes some standard procedure to evaluate the free loop.
I think Eva has now magnified the image and is going to adjust the scale, so the waveform should occupy approximately 2/3, approximately.
Yes.
And then something that happens very often is that you see what you are seeing here, and that here you're seeing fetal movements, maternal breathing, and so and this is going to happen very much with the middle cerebral artery. So that's why in general you take 3 waveforms that look more or less the same. In this case, you have so much diastolic flow that this case is normal, of course, and it doesn't matter very much. But if it's important, you could ask the mother to hold the breath for a few seconds, and then you will achieve better, more homogeneous waveforms.
Sometimes the image, the spectral Doppler, is contaminated by the umbilical vein, like here. When you have a very good high diastolic velocities, that's not an issue. But in those cases where you have to evaluate whether it's an absent diastolic flow or not, it could contaminate your image. So a practical tip to avoid that is to reduce the Doppler sample. But by reducing it, by setting it at the center of the vessel, it's less likely to get contaminated by the umbilical vein.
And once we have obtained a normal value in one artery, should we measure the other one?
That was the next question, Eduard. Yeah.
Can you repeat the question, Leti?
Should we sample both umbilical arteries or just one?
Okay, just one. That's why I should have done more zoom. Here we can see both arteries, yeah, and then the vein.
Yeah, but Eva, it's not if you sample one vessel. I think that the question is, we have to evaluate both vessels, not at the same time, but sequentially, or we take into account only the first evaluation that we perform in one of the arteries.
Okay, we would say if one is normal, we will keep with that one. If the first is abnormal, we should just check for the other one.
Yeah.
Okay, and we will just always keep the best one.
Just remember that each umbilical artery perfuses one portion of the placenta. Okay? And if you have one of the arteries working well, that should be enough. In most pregnancies, both arteries are connected at the base of the umbilical cord. So you should see more or less the same pulsatility index or the same waveform. Sometimes you don't. And if you don't, just consider that there is one artery that has a smaller placental territory. But if one artery has a good pulsatility index, this means that this baby has enough placental surface, and then you should take it as good.
That is especially an issue in fetal growth restricted babies, because those connections that you meant that equalized both arteries are immature, even at third trimester, and that it's why in a third of the cases there are large discrepancies between both arteries, and that is why always the best one it's taken into account.
So if the first artery is okay, that's it. If the first artery is not good, look at the other one and take the best of the two.
Yeah, and maybe we could show also just how to measure the umbilical artery, just a paravesical, because sometimes we ask for that. Yeah.
But put it in a clinical setting, Eva. In which cases would you opt to evaluate the umbilical vessel in the fetal portion, in the fetal insertion?
Well, when you have some technical difficulties, just to insonate properly the vessel. When you have, for example, no amniotic fluid, it can be sometimes more difficult. I don't know what else. Help me.
Sometimes in twins.
Essentially, when you have twins with very small amniotic fluid amounts and you don't know exactly which cord is from which fetus, and in this case, it is acceptable to go to the paravesical arteries. Otherwise, you should try to go to the free loop always.
As you can see here, we have both of them. Now we have the bladder. Oops.
Yeah, I think it's a very nice image, and you can do a Doppler here, Eva. You could magnify even further and do a Doppler.
Yes.
But that should be done only in exceptional circumstances.
Yes.
When it's normal in that portion of the vessel, you can assume that it's normal in a free loop. However, when it's abnormal, you should take extra effort and you have to locate a free loop. So it's good to rule out abnormalities, but it's not a good option to rule them in.
Normally, you should find a higher pulsatility index here. In this case, because it is normal, it makes no difference. But you should see that the relation between the systole and the diastole is going to be higher when you do it in the paravesical vessel. So that's why it's not the optimal.
Yes.
And the contrary happens at the placental insertion.
Yeah. the resistance is lower.
The
Yeah.
PI is always better than at free loop.
And I think don't get obsessed when you get different PI values, okay? That's very normal, okay? What you should be concerned is whether these PI values are okay. If they are falling within normality, that's it, don't worry. That the Doppler is a very dynamic measure and it's normal that it changes very much.
And the other question they are asking is that if we have a single umbilical artery case, can we trust the Doppler values or should we adapt them?
Of course you can. In terms of placental insufficiency, very much the same that you trust when there are two. You are looking at how blood goes through the placenta.
It has only a little lower PI, but it has no clinical impact. So you can use the common standards that we use for those cases with two umbilical arteries.
Okay, I think we could move to the brain, right? This baby is in bridge position or is in cephalic position?
It's a cephalic position. Okay. And the back is on the left side of the patient.
The problem you have sometimes with the middle cerebral artery when it's in bridge, when it's in the fundus, is that the breath of the mother is moving very much the head, and when it is in cephalic, that sometimes the head is very much inside the pelvis, and you have to force to get a good BPD. But in this case, clearly you have a good image, right? So how do you reach this plane, Eva? You start from the BPD, that's correct?
Yes, that's the BPD, and we go a bit down the baby, downwards.
And if you magnify without the Doppler, you will already see the vessels. If you magnify this, there is a moment where
thalami here, and we can see just the vessels. You can see here the arteries, and just here.
Here, actually, what you
can you see it? Because it's very
well.
nice. Yeah.
Very well.
What you can see here is the sphenoid bone. And it's why we should look at that plane to start our evaluation here, that one.
Yeah, gonna put the color, okay? We are just going to look for the upper vessel. So I'm moving a bit.
Now you tilt a little bit and you want to achieve a perfect line as much as possible. It's not always possible, but you should, in most cases, you should be able to get the image that Eva is showing here.
When it comes to the MCA, we are stricter in terms of the angle of insonation. So always aim at angles below 15 degrees. Because in almost all cases, you can obtain that good angle.
And that's a very nice case because in this case, the breathing of the mother is not affecting the movements of the head as it was affecting the umbilical artery. So that can be measured quite reliably. The only mistake you should avoid is that you press a little bit too much. Sometimes you get so obsessed and obtaining a good angle that you are pressing very much and you don't realize. But this is not the case here because we don't see any.
So we may just adjust, the gate a bit less than with the one we had for the umbilical artery.
And you're going to go as close as possible to the circle of Willis, but not into the circle of Willis, because otherwise you would be measuring the anterior cerebral anatomy. A very characteristic feature of the middle cerebral artery is that the pulsatility index is normally, especially at term, is normally higher than the umbilical artery. So you see that the diastolic flow is less.
It can even be absent during the diastole and even reversed, and is not reflecting any pathological condition. The higher the PI, the better. And Eva, sometimes you have a better angle insonating the posterior.
That's right.
Yeah, and that's fine. You should evaluate the one with the best angle, no matter the proximal or the distal one.
Yeah.
The other thing is, can you get different measures when you are measuring these vessels serially?
Yeah, quite common. It fluctuates during the examination because it reflects many physiological issues. So always we consider the best value that we obtain during the examination.
That's very important to remember. Always take the best value. Remember that the middle cerebral artery is extremely sensitive. If you put your mother in lying flat and she gets a little bit dizzy, you will measure the middle cerebral artery and it will be extremely abnormal. It's very sensitive to small variations. So if you have measured it and it was normal, take the normal value. Don't get obsessed. If you stay there for 30 minutes measuring, in the end, it will become abnormal because the baby will be completely exhausted of the pressure that we are exerting. These are perfect observations. And if you have that, you should take that as good. And this is the truth. But yes, when the mother arrives at your consultation and you are seeing at an abnormal value, repeat it because it is not uncommon that is not going to be confirmed. It could be low for different reasons. So you need to take several measures and always take the best of them.
Mm-hmm. As you were saying, never insonate just here, very close, because we would insonate the anterior.
Yeah, if you go to that, be close, but not that close. Okay, and again, the color is in the reverse. Now, I don't know whether this machine does that spontaneously. I mean, the colors are reversed again. The scale, the red should be okay.
Yes.
That's perfect. Okay, that's a convention to put the red in the upper part, but I mean, in general, we are more used to work like that. I think you can see very clearly the circle of Willis. You can, I mean, you can have very nice images of the circle of Willis, also of the posterior arteries by slight movements. You can see the whole circle of Willis in many fetuses. As they come close to term, it's more difficult because the bones are more ossified. But if you reduce a little bit the scale of the color, which is quite high now, you will see very nicely the circle of Willis.
Yeah,
and it has no other interest than, I mean, just looking at a nice image. So don't do that if you don't have a reason, and don't make the patient spend time, but you can see it very clearly. We take the middle cerebral artery, not because the other ones do not change, but because it's the vessel that has been validated. We have normality ranges, and it should be only in very exceptional cases that you don't measure the middle cerebral artery, and the value could be questionable. So it's always the middle cerebral artery.
If we should measure the other side one, or one is enough?
Can you repeat, Letty?
Yes.
MCAs or just the upper or the lower part, that the one that has angle?
Well, if you are insonating properly in the upper one, it would be more than enough.
Yeah, it's clear. Okay, maybe we could move on.
Just last question, I think, that can we measure it transvaginally, if not now in real time, but is it a good option to do it transvaginally if it's not possible to measure it transvaginally?
You can, but if you can measure middle cerebral artery transvaginally, you are so good that we will give you a job here. I mean, it's a very difficult vessel to insonate transvaginally. You can do it in case of very weird positions. Let's imagine that the baby is in a very rare position, and then you can measure it vaginally. That could be possible in some very rare cases. But look at how this baby is located and imagine how this baby should be located in order to be able to insonate the middle cerebral artery transvaginally. It's very, very difficult. It should be in exceptional cases, but well, if that's your particular case, that's fine.
Sometimes it happens that the head is too engaged into the pelvis, and you have to make much pressure on the fetal head to obtain that, and that influences the PI. And in those cases that are very selected cases, if the head is very engaged, then the transvaginal approach is an option.
It's an option, but remember that the baby should be in a perfect position. In some cases, you will not be able to do it because you need the vessel to be very well perpendicular to your probe. Okay.
So we'll move to the next one, to ductus venosus, I think.
Yeah. Okay.
Okay. Let's try a sagittal view. Okay, first, and then
So what are you going to do, Eva? You start from the spine. How do you do that?
Yeah, I'm just trying to find the spine first. Okay. And try to find the vessel.
So you will first look for the vein, right?
Yes. That's because the baby is moving quite a lot. Just here, okay? We have, okay, here we have the sagittal view. We have the
You have
vein.
the umbilical vein, which you can see very nicely. And then you should show, but
Okay. And it's, okay, so we just zoom a bit. And if we follow the umbilical vein,
maybe if you increase the scale, you will eliminate all these, or the
yes.
majority of these vessels that are making a lot of noise. The baby is moving now, which is not the ideal
Yes.
situation.
Yeah, this baby is moving all the afternoon. Okay, let's try again. Okay. Perdona, te aprieto un pelín aquí. Okay, here we have the umbilical vein.
Maybe if this mom is very tired, we could also change Eva.
Yes, we can try the other baby if you prefer.
No, we don't prefer, but maybe she's very tired.
Yes,
yeah. A lot.
Sí, podemos llamar a Paula si queréis. Let's try for, ¿vale? Haremos un cambio. We just meanwhile we're gonna try.
In the meantime, Letty, we have questions regarding the diagnosis, we can address them.
We had a repeated question that I think it's a proper moment to address it, because it's about if we should perform the ductus venosus evaluation in any case of fetal growth restriction or just in those who have an altered umbilical artery.
No, that's a very good question. We only have to perform it in a contingent way. That means that only if there is a suspicion, there are signs of placental insufficiency, that we have to interrogate the ductus venosus. The ductus venosus and the CTG, it's telling us that the baby has an acidosis or a very severe hypoxia. So do not perform it in all cases of SGA, only in those where there is a suspicion of placental insufficiency, are reflected by an abnormal Doppler and mainly by an abnormal umbilical artery Doppler. Otherwise, you are going to deal with false positive cases that are clinically very challenging because we don't know what means an isolated pulsatile ductus venosus. So don't look for it in all cases, only in those with placenta insufficiency.
Yeah, just remember. Yes, Leticia?
Go ahead. Continue, Eduardo.
No, just remember that the ductus is reflecting, in a way, the pressure of the right atrium. The right atrium receives the blood from the veins, from the cava veins, superior and inferior, but also from the ductus venosus. 30% of the blood that comes back from the placenta goes to the ductus venosus. And this right atrium brings this blood into the right ventricle. When the pressure in the right ventricle is high, then the ductus venosus starts changing and reflects that there is a high pressure. But you need to understand the clinical context. There are cases where you don't have growth restriction that for whatever reason, you would have variations in the ductus venosus. So as Frances says, I mean, you need to interpret this vessel in a context, because in a baby that is, even in a baby that is growing well, you should have no information. And when you don't have other signs of placental insufficiency, when your umbilical artery is completely normal, when your middle cerebral artery is completely normal, you should consider that any information from the doctors could be unreliable. So it's not recommended.
Okay, we're ready. Just
yes, please.
Okay,
Go
so
ahead.
it's a 30 weeks baby. Okay, we are in a cephalic presentation too. The back is in the left side of the baby. Okay, so as we mentioned before, we just look for the sagittal view, the spinal cord, and we look for the umbilical vein.
I think if you do a very good magnification without the Doppler, Eva.
Yes.
This is moving as well, but.
Okay.
Let's see if we can see the umbilical vein.
Yes.
You have a lot of shadows from the spine
Yes.
here as well. When you have a clear view, you can see the ductus in black and white. You don't even need the Doppler. Of course, the baby needs to be very still, and you need to have a very good projection. I mean, if you don't, then you better switch on the Doppler and then try to find these tiny vessels that arises from the end of the umbilical vein. And
probably.
Here,
Yeah.
So if you try, you will find it in many cases where the baby stands very still, but you see that, and you recognize it because the velocity accelerates. You see that it's brighter because the velocity is higher.
Here.
Yeah.
So we will zoom it a bit.
One of the difficulties with the ductus is there are so many vessels around, so many vessels that you really need to pick up the ductus. But if you do it well, then you will identify, you will have these very nice waveforms. Once you get these three nice waveforms, then you can already measure. You see the S wave, which is the first one, the D wave, which is the second one, and the atrial wave, which is the deeper wave, and this ductus has a lot of flow in the atrial wave, and then you can right away know that it's normal, of course, but you are going to measure it. I think now that you have measured, Eva, it would be nice if you can take out the Doppler, and then we take a look at the not the color, excuse me, sorry. The pulse Doppler. And then maybe by slight movements, you can then see how many vessels there are here. And sometimes we can see these vessels that come up very closely to the ductus that we don't see very well here, but there are the suprahepatic veins that are really, that can make your life very complicated, and you should not measure them because they are going to create false positives.
Yeah, well, just here, we cannot see them very well now, but maybe just here, that one.
Yeah, sometimes you see them better, but you should look at the very bright point. If it's not very, if it's not that you don't see an acceleration, this means that this is not the ductus, these are other veins and have a completely different waveform. Maybe you could place your Doppler there to see how different they are. And that's the typical pitfall when you are measuring a suprahepatic vein. Maybe you can insonate if the baby allows.
So we may consider maybe that one.
So you're trying to measure the ductus, you are really exhausted because the baby is moving, you don't know, at the end you see a vessel, say, okay, let's put my probe, and you see that. It reminds you a little bit of the ductus, but it's, well, there's a lot of noise here, of course, in this case. But some other cases are nicer.
Another tip to avoid that pitfall is to look always at the vessel that is more posterior, the one that is closest to the spine, not the anterior one. Because here the Doppler signal is quite good, and you can see a much brighter signal in the ductus venosus, but sometimes it's not that good.
That's true. The ductus is the vessel that seems to arise from the tip of the umbilical vein as well, but as Frances says, the most posterior one. So in many cases, you might be able to see the suprahepatic veins. We cannot see them now so well. But maybe, Eva, let's try the other projection then. Let's try the axial view. See if you can in this case.
Yes, the transverse view. Yeah.
The transversal view, yeah.
Okay.
The problem with the ductus is that if you start from the spine, you're going to have a horrible shadow. So you have to move a little bit until you see the typical shape of the umbilical vein. And again, let's try first with black and white. Let's try to get a nice image of the trajectory of the vein, if you can, Eva. I know I am asking you a lot because it's a 30 weeker and it's not so easy. But if not, we will go to the color right away.
See that way.
I think the other, yeah, you have a lot of shadow. You have to go laterally to avoid the shadow.
We have the vein, but I cannot just follow it very nicely.
I think it's quite difficult. Maybe the other approach was okay, but it's not an easy case, really. But just to illustrate that you can do it this way, and in some fetuses it's going to be easier. This one, you have this sort of J shape, and here you could switch on your color.
Mhm.
Sometimes you can see it very clearly, but sometimes not so much. So in this case, you will switch your color,
Yes.
and then at some point you will see this vessel that comes up.
It's here. Mhm. Not with the perfect angle, but
The problem is the angle.
let's try it here.
Okay, but as you can see, you can also measure it. Maybe you could magnify a little bit more, but I think you did a good
Yeah, trying to improve the
magnify
angle.
if you can. Okay, very
Just
good, very
here.
nice.
Most of the times, they are complementary planes. I mean, whenever it's difficult in the sagittal plane, it's much more easy in the axial
Yeah,
plane,
that's true.
vice versa.
Well, now the baby is moving, and I think we are going. I mean, you have shown how to do that, Eva. I think this demo is very good at illustrating why the ductus is such a difficult vessel. It is not easy. It is not obvious. When you have practice, you will find it in seconds. But the main problem is that even if you find it, the baby might be moving, and the
Yes.
projection might be not optimal. The only good thing is that when babies have a very severe growth restriction, they tend not to move too much, and then you could find it better. But sometimes they are in a very bad position. But if you are patient and you practice, you should be able to measure the ductus always. But of course, it's not the easiest vessel to start with, and as we said before, we don't always have the expertise available in all hospitals every day of the week, and that's one of the main problems with the ductus. I don't think there is better axial or sagittal. I mean, I think it's just take the best one you can, but you should be able to be proficient with both. And it's just a matter of practice. If you spend some time with normal fetuses with which you have some spare time, okay, the examination today was very easy. Okay, let's practice a little bit with the ductus. You will see must be able to find the ductus always. And remember, it's this tiny vessel that comes out of the tip. Adjust your color, wait for the baby not moving, and you will get excellent and outstanding views always. It's very reproducible, but when the baby is moving, like now, you might have to wait for 15 minutes. You might have to wait for 30 minutes to ask the patient to step down and then wait and then come back. And that's what makes it painful. And that's what makes Doppler painful sometimes. That you can really not measure a reliable ductus with a baby moving like that, okay?
Yes.
And particularly because breathing movements can falsify the ductus and can make it look very pathological. Just remember that when the baby is moving, the diaphragm is changing very much, all the pressures, and you can have very abnormal ductus. So I would say, as before, Francesc, you take the best measurement. When you measure a good ductus, that is a true, and this is what you need to take as good. Just magnify, Eva, magnify as much as you can. Don't forget to magnify your images always as much as you can, so you are sure where you are. You are patient. The angle is not perfect, but okay. But here you have it.
Yeah, the baby is moving, so we have
It's breathing.
versatile.
Yeah, the baby's
Yeah.
breathing, and that's why the atrial flow can be. And sometimes if you're measuring in the middle of a breathing movement, the atrial flow can even be reversed. But you have seen now, look, you are seeing these A waves that are clearly positive. So you have to be completely reassured that this ductus is normal, okay? Now it's mixing with some hepatic vein.
Yes.
And this happens all the time. So if you're having two very opposite ways, see how the ductus is much higher velocity. You see the hepatic vein is overlapping here, but when you are sure you have measured the ductus, You have this clear image, no doubts, you have atrial flow. This ductor is for sure going to be normal.
The hepatic vein.
Now you have a nice hepatic vein here, Eva. Try to insunate it.
Yeah. The
before
one
it-
below, yes, that
Yes.
one.
Yes. This one. Okay. Just adjust the scale so it looks bigger. Okay, you don't realize that you're measuring a vessel. So it might
That's
look,
right.
in this case, we have a lot of noise, but sometimes we don't. And you say, okay, this ductus looks very pathological. Okay, so be careful. Look at the velocity. This vessel has a much lower velocity. Look, we are operating with velocities of 30. So don't trust this.
There's a lot of noise here.
Now there is noise, okay? But just an illustration, and that is the very typical pitfall of, look, this is much nicer, and you see this baby is dying because this ductus is horrible. This is a pitfall, okay? You are measuring a vessel that is not the ductus. 30 maximal velocity cannot be, should be higher than 60, 70, and so you have to be completely sure. So if you have measured it normal, at least a couple of times, take this as normal, don't look any further.
And the opposite pitfall, it's when we evaluate the umbilical vein, but not the ductus venosus. Sometimes it can have
Yes.
pulsations, and you may be misled to think that it's the
That's
ductus
true.
venosus.
Just measure the umbilical vein a little bit down the ductus, Eva, so we can see how it changes.
Yeah.
Just go to the ductus and then move just 5
Yeah,
millimeters lower.
I'm trying.
A little bit higher, because here is
No,
not. It's not
Start
good.
with the ductus, Eva. Go to the ductus. This is the ductus, and we can see both ductus and vein here. You see the difference in the velocity. This case has a perfect flat shape in the vein, but as Frances says, some cases have some pulsations, and they can be very misguiding.
Or
Here-
maybe here, no?
Here they are.
Yeah,
That-
here they are.
That can be misinterpreted
Yes.
as with a ductus venosus with a very low pulsatility. So
Mhm.
again, the velocities and the anatomical position, it's what helps us in differentiating these two different patterns.
I think a very key thing is to magnify whatever is doing. Just magnify as much as you need to be sure where are you. Okay, and you can see clearly when you are in the vein and when you are in the ductus here. You see how it's bright, the velocity increases, you have the typical shape. You need to be very demanding with yourself, and you need to obtain optimal images. Okay. I think we are 1 hour and 40 minutes now into the 2 hours and 40 minutes now into the session, Francesc. Maybe
Yeah.
we could think of a last vessel if you want, or maybe we could give this demonstration for good.
Yeah, well, I think it has clearly shown how
Yeah.
to do it in a proper way. Just an overriding comment is that sometimes we neglect these quality criteria for the Doppler evaluation, and for the sake of time, we obtain vessels
Yes.
in a quite poor standard criteria. So it's always a good clinical practice to adhere to these recommendations. A Doppler evaluation, something that sometimes it takes time, but it should be done properly to have a clinical benefit. If you can
Yeah.
do it properly, then it's going to mislead you to take clinical decisions that are not based in a real pathological condition.
Exactly. So you will always find that one of the projections could be easier for you, but you have to be proficient in both. Okay. Remember that we need to measure the pulsatility index and look at the atrial flow. We look at both things. Okay. And the reason why the ductus is increased in fetal growth restriction is because there is an increase in the pressure in the right ventricle produced by acidosis. Okay, when you start having advanced hypoxia, acidosis, your right ventricle starts being losing elasticity, gets stiffer, and there is more pressure in this ventricle, and this is what the ductus reflects. So it reflects an advanced stage of hypoxia and acidosis.
Okay. Well, I was trying the aortic isthmus, but it's not in the right position just to look for that.
But as we said, I mean, I would not recommend you to spend time in measuring the aortic isthmus. It's a vessel that is not going to offer you any additional information in comparison to the umbilical artery. When you have reverse flow in the umbilical artery, you are going to have abnormal aortic isthmus. When you have normal or only absent flow in the umbilical artery, in the majority of cases, the isthmus is going to be okay, right? So it's going very much with the umbilical artery. Or umbilical artery normal, isthmus is going to be normal. Umbilical artery abnormal, isthmus is going to be abnormal. And you will only find 1% of your cases where these two vessels go separately. And that's the reason why we don't use it. It's a very difficult vessel. It takes a long time to measure. So I don't think you should make decisions for that, and you will not find it in our protocol. And I don't know, Frances, maybe we...
Yeah, I think that we can go ahead to the closing words of the session.
Eva, it has been an excellent demo.
Thank
Demos
you.
are always much more difficult than real life. And
Always.
thank you very much.
Okay, thank you.
Let me thank the models, the women that offered to collaborate with us because of the technical problems. We had to keep them for longer than expected. Thank you very much. Just translate to them our thanks.
Yeah, I will. Okay, they have been received. Okay, thank you.
That's good. Then we can, if it's right now, we can go to the take-home messages, and while doing the session, I pick up these key messages that we can take home. The first one that we discussed is that there are practical reasons for us to advocate for the estimated fetal weight rather than the abdominal circumference. We insisted that in low-risk women, the ideal window for routine scanning is 35-37 weeks, because it's then when we can pick up more cases of SGA. In low-risk women, the CPR at term, and look that this is highlighted here. Oops, something happened, sorry for that. Can you see my screen? Yeah.
Yes.
Good. My third conclusion is that the CPR at term can pick up some additional cases that are destined to have a very abnormal neonatal outcome. In high-risk pregnancies, you should offer serial scanning, and we recommend you to use the modified NICE criteria to identify early in pregnancy those at high risk. Something that came out from the demonstration is that the Doppler evaluation requires an standardized approach. Otherwise, we are doing a malpractice. Well, something happens here, but now I can keep on with that. The sixth conclusion is that the use of Doppler can help us in differentiating SGA from fetal growth restriction. And we have discussed at the beginning of the session that the angiogenic factors combined with the Doppler parameters at little, they can replace in some settings the Doppler parameters, but they do not combine well. We also have discussed that in order to classify the fetal growth restriction, we use the Doppler criteria that we have discussed during the session, and that we have then to offer an standardized follow-up and delivery according to the Doppler stage, to the classification stage. We have also discussed that in very early onset cases, let's say between 26 and 28 weeks, an individualized counseling is needed, taking into account other factors other than the gestational age or the estimated fetal weight, such as the fetal sex, the Doppler situation, and so forth. We have also mentioned that at term, the delivery route could be indicated by the cervical conditions and the CPR. They combine well in identifying those that will need an emergent cesarean section. And finally, we have also mentioned that in those cases, mainly with signs of placenta insufficiency, the mechanical methods are followed by a reduced incidence of CTG abnormalities that require emergent cesarean sections. And I think that these points summarize what we have said. And now I hand over to Eduard if you want to add some overriding.
Yes, no, I think you have covered everything, and of course that the only thing I wanted to say is that by definition, you cannot cover 100% of the questions that have been made, and of course there are details, there are nuances and there are. I mean, you can qualify statements and adjustment to individual situations. It's infinitely. It's very difficult to cover everything. We hope we have addressed the majority of. You can stop sharing your screen, Frances. I mean, most people will not care about your emails, but I mean,
nothing to hide.
No, I'm sure no. But I think, as I was saying, I mean, we are sorry for the questions. I mean, there's a big effort. Leticia is very concentrated, trying to pick up everything and to group the questions. Some of you might have connected live. We would like to connect with many more, but unfortunately, time is a limited resource in our lives, and we normally think that these sessions at least help to clarify. You can go over the presentations. I mean, there is a lot of content there. It's very concentrated. Just remember that some of the questions were asking things that are there in the presentation. So take a look at them again. We think that with all this knowledge, you can really update your practice. And I don't think we have forgotten any essential point, and that by taking all what we have has been discussed today, you can really offer your patients a very updated, adjusted to good evidence clinical practice. So I would, on my side, close here. Thanking very much, Leticia. Thanking very much, everybody. Thanking you for being with us. Really a very good number of people. I mean, it's normal that not everybody can connect live, but we have had more than 75% of the people that is registered attending live. We hope that the other ones will check at this session and record it. Remember that you will have it available, so if you want to go over it, you can do it as many times as you want until you hate our faces. But I mean, for whatever question you would like to go over, you have it everything recorded. And we normally also try to edit a little bit these videos so you can have some small titles with the question and you can move quicker. If you want, in a few days you will have that. So I have nothing else to say. I hope I forgot nothing. And Frances, maybe you can compliment.
That we are going to address the flip coin of fetal growth restriction, that is preeclampsia. Hope to see you all there.
Thank you very much. See you soon.
See you in the next one.
Bye.
Bye.